thank the organizing committee for inviting me here to speak at the International Diabetes Summit. And I shall be speaking on the use of dapagliflozin in high-risk cardiovascular patients and what the evidence foretells. Cardiorenal disease works in a continuum of which type 2 diabetes, which I'm going to focus on, is a cardinal point. Cardiorenal disease very often occurs on a background of various risk factors, which include diabetes, hypertension, dyslipidemia, obesity, smoking, altered nutrition, and through possibly various mechanisms that include, but not limited to, endothelial dysfunction, progresses to subclinical atherosclerosis and myocardial dysfunction on the other hand. And very often endothelial dysfunction is manifested as microalbuminuria, which is counted as a structural kidney disease. And then this progresses through stages of left ventricular remodeling, vascular stiffening, and finally ends up with coronary artery disease or diabetic cardiomyopathy on the one hand, but also in parallel leads to a loss in the EGFR with albuminuria, chronic kidney disease, ending in heart failure and cardiovascular death. If you look at the various randomized studies with SGLT2 inhibitors, they cover the whole gamut of patients, right from the multiple risk factor patient to the end stage heart or the renal disease patient. So you have declared to me 58 involving dapagliflozin, involving both types of patients, the primary and the secondary prevention cohort. You have the Canvas program doing a similar sort of cohort with patients. And then you have more sicker patients in the DAPA-CKD trial, in the Credence trial, and also in the DAPA-HF and the EMPEROR-R, which had reduced ejection fraction. In between, you had in the EMPEROR outcome trial, which dealt with essentially the secondary prevention cohort. Now, what I'm going to discuss is how does dapagliflozin fit into your high-risk cardiorenal patient? And we talk of high-risk patients in type 2 diabetes. You could have patients who are metabolically at a high risk, and this risk is very often defined by increased age, so elderly patients, as well as people with obesity, with high BMI and increased waist circumference. You could also have patients with cardiorenal high risk, which include patients that also have hypertension, a prior history of heart failure, chronic kidney disease, or some other cardiovascular event. Coming to age, now it is well recognized that we cannot have one uniform stringent goal for all patients who are elderly with type 2 diabetes. So probably you would aim for a more stringent goal like 6.5 or 7 to 7.5 or A1C in an elderly patient who is otherwise has a healthy functional status, who has no comorbidities, and who has a relatively short duration of diabetes. On the other hand, this goal is likely to be flexible anywhere between, say, 7.6 to 8.5 in an elderly patient who has a tendency towards hypoglycemia, a short life expectancy, comorbidities, various geriatric syndromes, a tendency to falls and fractures, disabilities, various functional impairment, and who's also on polypharmacy. If you look at the declared TIMI trial, you had patients in different age groups, and the data I'm showing you is the changes in the HbA1c, body weight, and the blood pressure as per the different age groups and the treatment allocation. So the line in blue is showing patients who are less than 65 years of age, the lines in red between 65 to less than 75, and the lines in green are patients who are more than or equal to 75 years of age. Now you find that the HbA1c, if you look at the top left panel, the HbA1c at baseline was relatively low in the elderly and the very elderly patients. But the change in A1C that occurred from the baseline was something similar in all the age groups. You can also see a similar trend in the changes in the body weight as well as the systolic and the diastolic pressure. Remember, declared TIMI trial had two primary endpoints. The one was, of course, the 3-point MACE, which did not show statistical significant benefit. But the other co-primary endpoint was the composite of cardiovascular death and hospitalization for heart failure. Now, in this primary endpoint, the dapagliflozin reduced this composite consistently in all the age groups. So even in the very elderly patient who are more than 75 years of age, this risk reduced by about 6%. If you now look at the DECLARE-TIMI trial according to the BMI categories, and we are looking at data for hospitalization for heart failure, you're looking at different categories of BMI from normal through overweight, moderately obese, severely obese, and very severely obese. The red, of course, is the placebo. The blue is for dapagliflozin. And you find that as the BMI category increases, the risk of heart failure as seen in the placebo arm keeps on increasing. Now, if you look at how dapagliflozin impacts this risk of hospitalization for heart failure, throughout the different BMI categories, the relative risk reduction is fairly similar. But if you look at the absolute risk reduction, say, for example, 5.8 in the highest risk category or the very severely obese, you find that the absolute risk reduction for hospitalization for heart failure is best. The benefit is highest in those with the highest BMI categories. Now you come to the duration of diabetes. Remember, DECLARE-TIMI trial had a total of 17,160 patients, of whom around 2,206 had a duration of diabetes more than 20 years. And if you look at the first co-primary endpoint, which I already spoke about, the composite of cardiovascular death or hospitalization for heart failure, you find that in patients with a duration of diabetes of more than 20 years, the dapagliflozin significantly reduced the risk of this composite by 25%. And that was in keeping with the trend seen in the other subgroups according to the age less than 5 years, 5 to 10, 10 to 15, 15 to 20, and what I'm showing you is more than 20. But what's interesting is the right panel, the 3-point MACE, which was also a primary endpoint. Remember, the 3-point MACE did not significantly show benefit in the DECLARE-TIMI trial, possibly because of the nature of the cohort. They had patients both from the primary and the secondary prevention cohort. But what's interesting is that in those patients with a duration of diabetes more than 20 years, in fact, the risk of 3-point MACE also significantly reduced by as much as 33%. And this was statistically significant. This was not so in those with, for example, a duration of diabetes less than 5 years. Now, this significant benefit in those who had a duration more than 20 years was largely driven by the benefit for myocardial infarction and ischemic stroke. And this benefit was irrespective of whether the patient had a prior history of a myocardial infarction or any other sort of multiple risk factors. Coming to the effect of dapagliflozin on systolic blood pressure, which is, I think, fairly well known. This is data from a prospective double-blind placebo-controlled study involving 52 patients, of whom half of these patients were also monitored in the first 6 hours after they had received a single dose of dapagliflozin. And also, the parameter was checked at the end of 12 weeks. So we have both an acute change as well as a chronic change. Now, both after a single dose, there was a reduction, a significant reduction in the systolic blood pressure by 7 plus minus 3 millimeters mercury. That's an acute change, but there's also a chronic change at the end of 12 weeks, which is something similar, 7 plus minus 2 millimeters with dapagliflozin. And they also checked certain levels of other parameters, for example, cyclic GMP, which is a vasodilator, and the level of cyclic GMP increased acutely following a single dose of dapagliflozin. So conclusion of the study was dapagliflozin administration in type 2 diabetes resulted in both acute and chronic reduction in systolic blood pressure, a reduction in vasoconstrictors, increase in vasodilators. Looking at another study done in 80 patients, this is a single center open label study, a randomized prospective study. You're studying, the patients are randomized 40 in a dapagliflozin arm, 40 in sitagliptin arm, and you're looking at these various parameters of lipids at the end of 12 weeks. Now, if you look at the lower panel first, you see that the LDL cholesterol in the dapagliflozin arm really does not change. Though I'll tell you later that out of 20 patients, out of 40, they did show an increase in the LDL. But this is important. The small dense LDL cholesterol reduced in the dapagliflozin arm by as much as 20%, and the large buoyant LDL cholesterol increased by 18%. These are all statistically significant changes. And in those patients, 20 patients in whom actually the total LDL cholesterol increased, actually the highest increase in the large buoyant LDL cholesterol was seen in this subgroup of patients. If you look at the changes in the HDL cholesterol, again, there is an increase in the HDL cholesterol by about 18%, but this change is rather in the 2C fraction, which is the cardiometabolically favorable marker, rather than in the 3C subgroup. So dapagliflozin suppresses the potent atherogenic small dense LDL cholesterol and increases the HDL 2C subgroup, and it does not increase the atherogenic risk. Heart failure is always a risk. If you have a history of heart failure, you're likely to have significant morbidity and mortality. So the risk of death rises sharply when the patient is admitted to the hospital for a decompensated heart failure. In the days after discharge, the patients with heart failure with a reduced ejection fraction are at a high risk of dying, and each successive hospitalization is associated with a greater risk of death in the long term. If you look at the DAPA-HF data, this involved, of course, patients who were diabetic as well as non-diabetic who had all reduced ejection fraction. And this is the placebo arm on the left and the dapagliflozin arm on the right. And the blue, dark blue is showing cardiovascular death as the first event. And the hatched blue is showing cardiovascular death, which occurred as a subsequent event preceded by some other event. And heart failure hospitalization as the first event, and the hatched orange is showing heart failure hospitalization as a subsequent event. Now, remember, in the total events, you find that dapagliflozin reduced the total events by 175. Whereas if you look at first hospitalization, there were 105 lesser first event as a hospitalization for heart failure in patients who were on dapagliflozin, and even heart failure hospitalization as a subsequent event was significantly reduced in these patients from 97 events in the placebo arm to 78 in the dapagliflozin arm. So the number of extra cardiovascular deaths and hospitalization heart failure is significantly reduced with dapagliflozin. Now, this benefit of dapagliflozin in the DAPA-HF study was irrespective of the presence or absence of diabetes. It was irrespective of whether the eGFR was more than 60 or less than 60, across different ranges of systolic blood pressure, across different background heart failure therapies and various devices that were being used in those various patients, whether diuretic therapy was a part of that therapy, whether they were on background sacubitril valsartan or not. And also it was independent of the baseline ejection fraction, the heart failure etiology, whether ischemic or non-ischemic, and the baseline NT-proBNP level. So consistent effects across all the subgroups were seen in the DAPA-HF study. Coming to another study, the DAPA-CKD study, which was in a high-risk population, the primary endpoint was a sustained at least 50% eGFR decline, ESKD, and renal or cardiovascular death composite, and then you had various secondary outcomes. And this study actually had to be stopped early because of overwhelming benefit of dapagliflozin. So dapagliflozin in this study cut the incidence of worsened chronic kidney disease by an average of 39%, with the number needed to treat of 19 to prevent one primary outcome event after a median of 2.4 years. You can see the overwhelming benefit: 39% relative risk reduction for the primary outcome, 31% for all-cause mortality, 29% for the composite of cardiovascular death, heart failure, hospitalization, and 44% for the specific renal endpoint composite. So dapagliflozin has been proved to be a game changer. And in fact, it has been included as the guidelines have included dapagliflozin as a first-line drug in diabetic patients, type 2 diabetes, with established atherosclerotic cardiovascular disease. And with the DAPA-HF results, the DAPA-CKD results, the various international organization guidelines have now been updated. So this is actually now, in the Indian setting, the only affordable SGLT2 inhibitor for glycemic control, for heart failure with reduced ejection fraction, and chronic kidney disease. When you discuss the various SGLT2 inhibitors, you have three drugs: empagliflozin, canagliflozin, dapagliflozin, all with good, best assured utility in terms of benefit for renal events, myocardial infarction and stroke events, heart failure events, and even quality of life and life years. but then very often drugs with the best utility necessarily are not always cost effective. So in the Indian setting, actually, there was a very interesting questionnaire addressed to about 844 endocrinologists, diabetologists, cardiologists, family physicians. And in fact, 54%, majority of these physicians said that there's an issue of affordability with their patients, and therefore they had to use drugs which were cost effective but really do not have evidence. I'm referring, of course, to Remagliflozin. So you obviously need a drug which is not just cost effective amongst these agents, but also, the best assured utility, but also cost effective. And now that generic Dapagliflozin is available in the Indian market, I believe this was now soon becoming a mass drug treatment for all patients, including the categories I just spoke about. So take-home messages from my lecture. For decades, the good glycemic control was the only way to reduce the cardiovascular and renal risk in diabetes patients. Dapagliflozin has impacted type 2 diabetes, heart failure, chronic kidney disease guidelines across the globe to define a new standard of care to use it as a first-line treatment in patients with high risk and established atherosclerotic cardiovascular disease. In treatment-naive patients, dapagliflozin, of course, well tolerated, effective in reducing A1C, fasting plasma glucose, and weight. And now with the introduction of low-cost generic dapagliflozin, we now have an effective, safe, reasonable choice for treatment of type 2 diabetic patients with multiple risk factors and diabetic comorbidities. So that dapagliflozin should be initiated in high metabolic, high cardiorenal risk patients as a first-line therapy. Thank you so much for your patient hearing and your kind attention. Thanks a lot once again.